Hi, good afternoon. I'm Elena Hawryluk from Boston. I'm from Harvard Medical School and I work at Mass General and Boston Children's Hospital. I hope everyone's been enjoying the conference. I know I have, and I know you've just heard a lot about different types of basal cell carcinomas. So we'll move ahead now and talk about topical and surgical management of basal cell carcinomas. I have no relevant conflicts, and we'll pick up right where we left off in terms of types of basal cell carcinomas and what makes them high versus low risk. This is the most important thing to consider in determining how we're going to treat our skin cancers when they pop up. So I'd like to go over these features. On the left side of the chart, you see the low-risk basal cell carcinomas, and these are small lesions, so less than 1 to 2 centimeters. The pathology report will show that they are low-risk types, such as superficial and nodular, which are the common ones that arrive in Gorlin syndrome. And the location are lower risk sites such as the trunk, extremities, the cheeks and forehead, the scalp, the neck, and the shin. And other features are that low-risk basal cell cancers happen in well-defined areas. They're a primary lesion. It's not in a radiation site, and the patient's immune system's intact. There are certain features that make basal cell cancers high risk, as you'll see on the right side of the screen, and these are the larger lesions that pop up, greater than 1 to 2 centimeters. The locations that are higher risk are at the central face, the hands and the feet, and the features that we see on the pathology report that tell us that it's a high risk or more aggressive lesion include words like morpheaform or sclerosing or infiltrative. And so it's important to know, based on the pathology report, that will also inform the decision. And then other features, of course, if a basal cell carcinoma is arising where there's a scar from a prior lesion, a site of prior radiation, these are features that tell us it's a more high-risk lesion. So once we've decided whether our lesion is high risk or low risk, we can talk about the different options for treatment, because the low-risk lesions have more options to treat safely. And we'll start right at the top of the pyramid from surgical treatments, and we'll move right down through minimally invasive procedures, topicals, chemotherapies, and others. So our first stop will be at surgical treatments, and this is first because it is the most common treatment for basal cell carcinoma. It also has the best cure rate. And we're going to look at this chart in 2 halves. So on the left half, we'll talk about excision, and on the right half, we'll talk about Mohs surgery. And these are 2 types of surgical management techniques. So on the left, we're talking about excisions, the most common treatment method for basal cell carcinoma. It's the first-line therapy for fast-growing lesions and those that are limited in number. They have a very high cure rate. And unfortunately, though, an excision does involve scarring that's a little bit more significant in that you have to take a safety margin around the basal cell carcinoma to ensure that you're removing the entire lesion to reduce the risk of it recurring. And of course, along with procedures, we think about associated anxiety or office visits, the risk of infection, bleeding, healing. And so for patients that have multiple basal cell carcinomas, it may not be the ideal choice. Excision is the mainstay and is the most common, especially when the location of the basal cell cancer is in a good site that has enough space for a safety margin. But there are a lot of places where excision won't work. And that's where Mohs surgery, which is a particular type of technique where a specialized dermatologist called a Mohs surgeon is able to take a small piece of tissue, so they try to remove the entire tumor, and while you're in the procedure and waiting, they actually look under the microscope and check all of the borders of the lesion to make sure it's completely removed. And sometimes, if we're lucky, of course, a single stage will remove the entire lesion. If the lesion is positive at a border, that expert surgeon can go back to that same exact place on the lesion and take additional safety margins. So that would be called a second stage of Mohs surgery. And some patients do require multiple stages. Each stage is checked, and that way they can have the minimal amount of tissue removed from the skin and have the highest cure rate. So the cure rate for Mohs surgery is 99%. You've got great margin control, and it conserves the most amount of tissue, so it's the best treatment to use on places like the face or the ears or the hands where you don't have a lot of extra skin in the area. The cons, of course, you may be experienced in knowing that this can be quite time intensive. It takes time to take each layer and look under the microscope, and it can be a long process. So if this is something you're planning, please bring a book or your iPhone or something to keep you busy. It is a bit more expensive, and like any surgical procedure, it does involve scarring, bleeding, and discomfort of a procedure, along with that anxiety that goes with that. So surgical management is the most common, but we do have other options that I really want to make sure you understand in detail. And so we'll move to our next slide. Connection is lost. Here we go. Minimally invasive procedures. So this refers to different procedures that we can do in the clinic, such as electrodesiccation and curettage, also called ED&C, photodynamic therapy using light, and laser ablative therapy, also using lasers and light, and cryotherapy using liquid nitrogen. And so these are great options for particular types of basal cell carcinomas. And this slide is quite detailed, but we'll go through each of them one at a time, starting at the left. So ED&C is also known by patients as scrape and burn. This is a very quick procedure done right in the clinic where the area is numbed, and we use a combination of two techniques. So first is frictional with a special tool called a curette, and then the lesion is also treated with electrocautery, and it's done in 3 separate cycles. It can be done in just a few minutes. This type of procedure does leave generally a pretty significant round scar at the area of treatment, but it does achieve pretty good cure rates. And for our patients, we talk to you very carefully about how to take care of the site after the procedure. There's no stitches, and oftentimes you can get right back to action after it heals. The second on the list is PDT, or photodynamic therapy. And this is when your site that's to be treated is received a topical medication that sits on the skin for several minutes to activate the lesions. And then there's a special corresponding blue or red light, depending on your activator. And this is a great technique to treat a field of area. So if you have several basal cell cancers or suspicious areas in the same location, an entire area such as the scalp or the forehead can be treated in one treatment setting. So this particular technique does have a really good outcome in terms of scarring and cosmetics. It can be preventative, but the cons are that it does sometimes require multiple lesions, and the areas that are treated can experience some pain or redness, almost feeling like a bad sunburn after the treatment, taking a few days of downtime to recover. The next treatment that we'll talk about is laser therapy. And so this is what we're referring to when we talk about zapping a lesion. This can be used to treat multiple basal cell carcinomas at the same time and can be used in combination with other therapies. Again, it may require multiple visits, and you can have peeling at the sites treated for up to a month and even scarring at the treated sites. And the last on this list is cryotherapy. This is referring to freezing using liquid nitrogen. And this is a fast and safe treatment. Often you don't even need topical numbing medicine. The treatment itself can be done in a matter of seconds. It takes a little while for each freeze-thaw cycle, and it will generally leave the tissue in a state where you have a blister, and the blister takes some time to heal, and it often will leave a white mark on the skin as it heals. I wanted to point out that each of these types has cure rates in a range. So you might note that ED&C, 91 to 97% compared to, say, laser therapy, 79 to 100% cure rate. And this is really dependent on the experience of the operator for these techniques. So there are some people that do these things a little differently than others and have really good experience and can achieve higher cure rates. So minimally invasive therapies are most appropriate for low-risk lesions. So these are the superficial or nodular basal cell carcinomas. All of these therapies may also be used in pediatric patients, so with or without anesthesia, and we have a lot of tricks that we use in the pediatric population to keep our patients comfortable and distracted while we do procedures if we need to. And these approaches can also be useful for targeting potential or unbiopsied lesions, preventing the need for biopsy. And so there's a little risk when treating sites that you don't have a good confirmation of. So you need to really work closely with your dermatologist if you're looking to use these approaches without having a confirmed biopsy first. Moving on to our topical treatment options. And so this is referring to 5-fluorouracil, imiquimod, and ingenol. And so these medications are prescription creams, and we'll go through them. On the left side of this graph in color, you see the 3 different medications that we've referred to, their cure rates and duration and frequency. And while we'll talk about each of them separately, the pros, cons, and uses are all very similar for all 3. They can be done at home by the patient or a caregiver. It's a good option when you have multiple lesions, and they're less likely to scar than procedures that often involve stitches and downtime. The cons are, of course, when you're using a treatment, it can cause a lot of inflammation, itching, or even pain and crusting. And this treatment reaction is often variable from patient to patient. Some patients have an incomplete response with not quite enough inflammation, and you really have to be consistent with the use to be confident in the full treatment course. We use these treatments on the right here for low-risk superficial basal cell carcinomas, and you can use them for low-risk nodular basal cell carcinomas, though they may be less effective. Also, they can be used for non-biopsied early suspicious lesions, but again, in both of those settings, you really want to make sure that you're following closely with your dermatologist so that you can shift gears to a different approach if that's appropriate, and certainly biopsy if needed. In terms of the 3 main topical treatments that we use, 5-fluorouracil, the brand name is Effudex or Carax. This is often used once or twice daily for 2 to 12 weeks, depending on your regimen. And this is relatively inexpensive and has a comparable efficacy to both imiquimod, which we'll talk about, and photodynamic therapy. The next on the list is imiquimod. Different regimens have us using this 3 to 7 days per week for 4 to 8 weeks. And this may be more effective than PDT. One of the interesting things about imiquimod, the brand name often uses Aldera, is that flu-like symptoms have been reported. And this is because this medicine works by activating the immune system at the site of the tumors to help the body respond there. And some people are more sensitive to it and have flu-like symptoms, which should cause you to stop this medicine and seek a different pathway. The last one, ingenol, is brand name Picado. And a lot of people like this because it's once a day for 2 to 7 days. So it's a shorter course with a faster response. But it is the new kid on the block. It has least amount of evidence for it. And again, always using these topical medicines in concert with close clinical follow-up. Some patients ask about topical retinoids, such as tazarotene or tretinoin. These are great tools. They can help with acne, and they also act as photopreventative basal cell carcinoma measures. The success is variable, and you'll see the success rate of 28 to 64% efficacy. This is not what we're reaching towards first, even though it may have some helpful role. Moving on to our oral treatment options, and these are also new and exciting medications. We'll talk on the left about vismodegib and on the right about sunitigib. These are 2 excellent new medications that are for locally advanced basal cell carcinomas. They do have higher complete response rate in clinical trials and higher overall response for metastatic disease. They're also approved for metastatic basal cell carcinoma for vismodegib. On the other hand, sunitigib has more GI side effects. And we'll focus on the middle, daily oral medications that inhibit the hedgehog pathway. And we'll talk about that. They're approved for adults for recurrent locally advanced basal cell carcinomas and those with locally advanced basal cell carcinomas who cannot undergo surgery. And so I'll point out what is the hedgehog pathway? This is a signaling pathway in cells that tells them when to divide. And so this is the pathway that is not regulated properly during basal cell carcinomas and also in Gorlin syndrome that causes these lesions to arise. What about children? This is unfortunately not currently approved in children, and it's important to note that when it has been used in children, clinical trials have showed early growth plate closure. And what does that mean? It means that if you're not done growing, that you may not grow to your full height potential. And so that's important to consider for our youngest patients. In terms of how severe are the side effects, and we're talking about muscle spasms, hair loss, changes in taste, and weight loss. In clinical trials, these adverse effects led to discontinuation in 1 out of 4 patients. And I do want to point out that clinical trials are brief, and so they are not measured ongoing or continuous forever. And in real practice, the patients who I've met who have tried these tend to find that they can stick with the medicine for a while and do have trouble with some of these side effects causing them to discontinue. I think it's really important, and I would love to hear your own experiences for those of you that have used these medicines. And please, I'm asking you during the question and answer to provide and share your input and insights so that we can all learn from you too. And now we'll move on to the last category, and so new, up and coming, or things that people are talking about in terms of treatment. And so I wanted to spend a moment and talk about melatonin, as I've received a number of questions about this. And so there is some interesting information spread around about melatonin. 3 to 10 milligrams taken before surgery or procedures may reduce anxiety in children and adults. And so this is something that we hear about. I would say it's not been robustly studied, but melatonin is overall a very safe supplement, particularly when you get it from a reliable, trustworthy source. As you know, many of the supplements, they're not regulated by the FDA, and so I always encourage people to obtain supplements if you're choosing to buy them from places that are reliable. Melatonin may inhibit tumorigenesis, so the development of new lesions, and it does have anti-inflammatory properties. If you add melatonin to chemotherapy or radiotherapy regimens, it may improve the effectiveness and reduce adverse effects. So this is exciting new data that's performed preclinically, and we're awaiting more data from clinical trials before we recommend this as prime time. But in the meantime, it is certainly a supplement that's easily accessible. We use it even in young children who are having trouble sleeping at night. So I think from a safety perspective, that's good news. And I certainly would only use it at the doses recommended. But I do want to emphasize there are no clinical trials reporting on this, and melatonin does not have approval or indication, though I don't think it's particularly harmful if you'd like to give it a try. A word on radiation therapy. So this is a type of treatment that's used for other types of skin cancer and certainly basal cell cancers in some contexts, but this is not recommended for Gorlin syndrome patients. We know that Gorlin syndrome patients have increased susceptibility to induction of new basal cell carcinomas when they're exposed to ionizing radiation. So please avoid this treatment approach. And this also plays in nicely with preventative management. We all know that we want to minimize exposure to sunlight, use our sun protective clothing, daily SPF with reapplication if you're out for a long time, and avoiding those peak hours. In terms of avoiding radiation for medical purposes, if imaging is required for medical diagnostic reasons, we would favor an MRI or the magnet better than CT radiation. And so towards the end of the slide, I just want to recap the factors that we like to consider when selecting treatment. And so these are in blue. I think the most important, of course, is the cure rate, how successful is the treatment, and the lesion features. So the location, the number of lesions, the recurrence risk. And this will tell us if it's high risk or low risk, the low risk being eligible for more different treatment options. Side effects are absolutely important. Each individual patient will have their preferences of which treatment is best for them, that they like the best, and it's really important to make these decisions together. In terms of convenience, certainly the number of treatments or office versus home are very important to consider. And lastly, whether patients based on their age, cost, or surgical candidate status may absolutely influence the treatment plan. And we'll just wrap up with some take-home points. Treatment of basal cell carcinoma in Gorlin syndrome is challenging due to the high number of lesions. Alternative therapies to surgery are available for low-risk lesions, and some therapies can be used in conjunction with surgery. Research for the best management in Gorlin syndrome is ongoing, and I think the best research and best input comes from our patients, so I'm looking forward to you educating me. And prevention is, of course, a key part of basal cell cancer management. So thank you for your time, and I'm excited to take a break for questions and continue with the conference.
Thank you very much. That was great, Dr. Hawryluk. We've got a few questions, and then if we have time, I've got some of my own after listening to your presentation. And I love your last slide, looking at the whole picture. The holistic approach is so essential. And I also, a point that I think we should make is that if you are not comfortable for yourself or your child with the approach of a physician, find another one. This is a lifelong thing. You need to build a strong team, and a dermatologist that you're comfortable with is essential. So why don't we go to our first question now? Will a topical treatment for basal cell carcinoma be available in the near future for everyone? How soon? Well, you've already discussed a few topical treatments, and I'll let you continue.
Absolutely. I do think we have some good topical options right now for the superficial and nodular, the early low-risk types of basal cell cancer. But I think what everyone's asking is, when will the topical hedgehog inhibitor, pathway inhibitor products be available? And these are in clinical trial. Dr. Tang spoke earlier today about a product that's new and in phase 3 trials that hopefully we'll be reporting in the next upcoming year. And they are currently being studied with clinical trials. So I do think that work is ongoing here, not only with hedgehog pathway inhibitors. There's some work on topical itraconazole, and that's an antifungal that's readily available and safely used for other medical problems that may have some efficacy and is still being studied. So there are a lot of exciting new options. Certainly right now, I like to focus on the ones that are approved and available on hand, but when those are exhausted, that's when we need to get creative.
Yes, exactly. And there are some other topicals coming down the line that I'm very excited about, and we'll be sharing more information when that's permissible. So what's our next question then? Let's take a look. How do we know if they're effectively eliminating BCCs or covering them up and potentially causing more growth under the skin? Shouldn't we expect to be informed after a clinical trial if we're receiving the medication or placebo? So let's just start with the first question.
So one of the reasons that topicals are generally reserved for the low-risk type of tumors is that if you have a high-risk type, and these are the ones that are referred to as morpheoform or sclerosing, these are sneaky and really hard to see underneath the tissue. And so it's really important when you're using a topical treatment that it's either biopsy confirmed as one of the low-risk types or clinically diagnosed as a low-risk type, that we can be confident that the treatment and its reaction is effective to completely eradicate that tumor. I do worry about that very problem for higher risk types of basal cells, that you can treat the surface and there is sneaky action underneath the surface. So really, in terms of having a firm diagnosis before treating and an excellent plan with your dermatologist who's recognizing what's appropriate for which location. Remind me the second question.
Well, I'll go ahead and answer the second question for you. I think that in response to that, the best way to get that information is to talk to the location where you've participated in the clinical trial. They will be able to give you as much information as they are permitted to do so. And do you have any further comment on that, Dr. Hawryluk?
Yeah. I do want to say that clinical trials are intended to help people, and whenever there is a demonstrated difference between an intervention and a placebo, that trial is generally halted and patients are given the treatment that works. No one is putting patients into a trial where placebo is less than the standard of care, so you will always be receiving a treatment that is felt to be helpful in some way, and that's why we compare new medicines to medicines that we already know help in some way. And so I think we can trust our trials and that they're set up by IRBs and people are really looking out to protect our patients. and that there's opportunities to deliver effective treatments and change the trial if it's really showing an intervention to be more helpful.
Agreed. Thank you. And our next question. If you're using the topical and not getting redness or an irritated look, then is it going to get the desired result? And then, is the Mohs the best remedy? You've already really addressed the second part here in your talk, so maybe you can focus on the first question there.
When we treat patients topically, we are expecting inflammation and a reaction at the site. And I would expect that if there's no reaction there, that medicine hasn't done its job. And so that's really emphasizes the importance of clinical follow-up to reevaluate the site after the treatment course, because we absolutely have some patients that respond to one treatment and not particularly another. I do want to say about the second question, is Mohs the best? It does have the highest cure rate. And so if it's a numbers game and you want the treatment that will have the least amount of recurrence, that's the one that would have the highest cure rate. But each patient, each lesion, each location needs to be considered individually, and it's important to have that relationship with your doctor who can help you navigate this process.
Great answer. Thank you very much. And our next question. What is the effectiveness of Araveg, long-term dose and side effects? Some of these we've covered somewhat. Effectiveness of laser therapy to remove BCCs. Which laser is most effective? Is one laser more sufficient to remove the cancer? I'll let you go ahead with these, and maybe they can be left up on the screen so we can cover them all.
I'll dive right in. These are excellent questions. Thank you so much for your interest in asking them. So the first question, in terms of the effectiveness and long-term doses and side effects for average, typically it depends on the subtype of basal cell cancer, and so the studies do show a response rate of nearly 70%. You have to worry about those side effects. Dr. Tang mentioned briefly muscle cramps, taste loss, hair loss. A lot of these are reversible. Sometimes the hair loss is not reversible. Some patients don't have these side effects, and that's wonderful. And a lot of times the side effects are severe enough that they limit treatment. So every patient is different, and I would go into the situation as optimistic as possible, and I really wouldn't continue a medication that's causing more morbidity or side effects than one's willing to consider in that. In terms of laser therapy, there are a number of different lasers used. The most common one is the CO2 laser. This is a laser that basically destroys the tissue. It does require multiple treatments, and so clinically evaluating the lesion and the site after it's healed is the best way to approach these. Laser therapy does have a range of effectiveness, and that's because of different lasers used and different users that are comfortable with different settings and outcomes. If you set a laser too strongly, you could have scars at the site just from the laser alone. So it's careful to work with somebody who has experience in this area. And the last question was the basal cell cancer on the tip of the nose. It is a high-risk location, and certainly if the lesion appears high risk, I would be in favor of Mohs surgery to clear the lesion. And then there are a number of options for repairing that defect that's left from surgery. I'm not a surgeon or a Mohs surgeon. I'm a pediatric dermatologist, so I will hunt and find. But I can tell you we see great results for our patients with very high-risk areas and very prominent scar locations. And one very common trend we see now is healing by secondary intention, so allowing the skin or the defect, if it's small enough, to heal in alone. And so your surgeon will be the person that can tell you whether letting it heal by second intention, closing primarily, or doing a flap or graft or very sophisticated surgical technique will give you the best option in their opinion. And if you have a scar, there are ways to treat those scars afterwards with lasers and additional procedures to help if needed.
Thank you very much. And the next question, and we'll keep in mind here that these questions were submitted prior to these talks, so there may be some redundancy, but we'll cover what we need to that we haven't already. How soon will there be a topical treatment available for basal cell cancers in the skin on the ears? Available for use beyond clinical studies.
I'm waiting with you. I'm hoping for news
Yes.
in the coming year on the study, and then we'll go from there.
Agreed. Fingers crossed.
Yes.
And next question. What UV level is it safe for somebody with Gorlin syndrome to go outside without sunscreen? Good question.
I love this question. I get questions about sunscreen all the time, not only from Gorlin syndrome patients, but melanoma patients and children with funny moles. And sunscreen is one of those things I like to think about like brushing your teeth. Would you ever ask a dentist, like, how many times a week do I have to brush my teeth, or how many times can I skip? You know the answer is going to be wear it or brush your teeth all the time. And sunscreen is the same in my book. I personally wear sunscreen every day. I recommend that we all protect ourselves, and I like Julie's approach of putting it next to the toothbrush, next to the deodorant, things that we wouldn't leave the house without. I'd like to consider sunscreen right along with that. Now, my smart and sophisticated young patients will sometimes say, the UV index is really important, and I agree, and it can really guide us on how frequently we need to reapply to protect ourselves well. But I get into the habit of it every day, and if you don't like the sunscreen you have, there are many different types. There are creams, there are gels, foams, wipes. I can even find a type of sunscreen that my own parents will wear. So there are different sunscreens for everyone, and hopefully your dermatologist can help you find a good match.
Exactly right. And we'll be talking more about sunscreens in a little while with another speaker in our third session. So now our last question, please. How much protection does a normal double pane window provide regarding UV? Great question. Another one.
I had to look up the numbers just to be sure for you. But UVB is actually, there are different types of UV radiation, A, B, C. UVB is the most common one, and I always like to remember UVB makes you burn. And UVB is typically blocked by windows. However, about up to 75% of UVA can pass through windows, and all UV light can cause UV damage. So I do like to remind everyone to wear your sunscreen even when you're not going outside. So sitting by the windows, you can still get UVA damage. It won't give you a burn, but it will still affect your cells of your skin.
Dr. Hawryluk, thank you so much for this great presentation. I really appreciate it. And we've really learned a lot today, and I'm sure many people will be able to apply that to their lives going forward. At least we hope so, right? So thank you again, and enjoy the rest of our conference and your weekend.
Thanks so much. I just wanted to say thank you, and it's been such a pleasure to be here and also to care for the youngest patients who have Gorlin syndrome. So I love my pediatric dermatology patients and look forward to helping anyone I can.
Thank you very much.